The first place I'd like to start, I want to at least separate not only clinical integration from ACO, but too often we overlook the topic of financial integration. I've spent quite a bit of time in the last several weeks with some area hospitals and really having focused groups with independent practices that are very loyal to these hospitals. And and this topic is very fresh because too often we'll go around the table and we'll start talking about ACOs or payment reform, and they'll immediately start talking about, well, I'm considering becoming employed, or I hear about this leased arrangement or a PSA. Is that the same as participating in the network to take on some risk? And I think it's important to take those two and separate them a little bit. One doesn't mean you have the other. So Advocate was brought up just a minute ago. That's a terrific example where they've proven that you don't need to employ everyone to have a successful network and have a high level of care coordination with aligned incentives. And I think this market in particular is grappling with this emotional drive of a lot of these practices feeling like they need to become employed or become financially integrated with the system in order to participate and be an active participant and be loyal to that network and be treated as an equal. And so the two, what I'm trying to separate here is to the extent to which your business, your practice, is financially integrated with the system, whether it's through an exclusive contract or whether you're employed, does not necessarily mean that you're clinically integrated and that you're coordinated with the other primary care specialists within the system. I can cite many examples where there are large systems that have 700 employed physicians, but it's extraordinarily fragmented. There's not a good forum. There's not a good governance structure for the physicians to have a voice. It is many layers down, but yet the idea is, well, we have 800 physicians under one roof. That must mean clinical integration. It doesn't. And so I'm trying to draw this distinction. And just if you had to pick a few spots on each of the spectrums, on the bottom, financial integration, obviously again, not suggesting that it means clinical integration or coordination, but employment, meaning you are employed by the system. On the surface, you should have the same interest as that system. And in the middle, you could have a shared risk arrangement, and to the left, you could be merely on medical staff and have no financial relationship with that hospital. So I just want to at least put this in some context, because when we go forward in these slides, this is not a talk about the financial integration of a practice in a hospital. And maybe I'm a little biased in this, but based on our experience and what we've seen and outcomes, and we're working with MIT to look at this a little closer, there's not a direct correlation between the extent you're financially integrated and care coordination, outcomes, quality, reducing costs. And I would agree wholeheartedly with the point made earlier that it's not going to be the administrators and others that are going to get the costs out and promote quality. The physicians need to be deeply involved. So at a leadership level, at the governance level. And to draw this point out just a hair further, you can look along the bottom and say, whether you're an independent practice or an employed medical group, is there a correlation between whether you end up as an employed medical group, multidisciplinary, multi-specialty group in a large system? Does that position you better to take on risk with the payers and manage the population? I think the verdict is still out on this. Another example would be a group that is clinically integrated, tied together, but now is in a position to share information on the same EMR as the hospital. And I'm bringing these up because they're examples successful examples where they've taken on risk, they've reduced costs, they've distributed incentives, and it's not tied to the organizational design of the practice, either as an independent group or within the system. The three core attributes of any ACO, if you boil it all down, and I'm sure you've seen this, but really is at the core. It's simple. You have organized care, meaning you need to have a meaningful relationship between the hospital and the physicians. One that there's truly a sense of accountability, shared accountability, and that you're looking at in its entirety the population and the level of care in that community. You need the payment mechanisms to provide those incentives, so payment reform and a gradual shift from volume to value. I think this is another popular thing to discuss where everyone wants to, they aspire to be there. But even in Boston, that's a pretty progressive market. I know there's probably some of you in the room that are already taking on some risk, but are nowhere near the level of taking on, shifting from utilization to value where they aspire to be. And I just spoke with a large department of radiology that is looking at this and not knowing quite the tactics they're going to adopt to reduce, because right now they don't have the incentive to reduce utilization. So I think, again, this is an area that if you peel back the curtain, there hasn't been a tremendous amount of success or results yet by truly shifting to value. It's also reflective in compensation plans for employed groups. It's still dominated by work RVUs. I mean, we can talk about value, and we can talk about adopting quality metrics, which is the right thing to do. But if you go out and look, and you ask your colleagues, it's still dollar for widgets. And so this is going to have to change gradually, but it's not going as quickly as I think we all think it is. The last is performance measurement, and this is overlooked too often as well. We have clients, both large physician organizations, supergroups that have been formed, or systems, and they want to form an ACO, and they want to take on risk, and you go in and they don't have the capabilities to legitimately measure quality or the infrastructure to look at costs, and sort of have an attitude of we'll sort of wing this, we'll figure it out. It's overlooked. It's a significant undertaking to make sure you have the infrastructure to actually report out on this, and that it has high level of integrity. When you bring the administrators and the physicians in the room to pour over this data, the credibility can plummet if these systems aren't consistent and timely. I found this intriguing. I'm sure many of you have maybe not read every page of this report, but the report that came out from the AG's office in late April. I mean, even at least the executive summary you should read. That under the providers section, I thought this was telling that it's not a glowing score report card on where we are in the state. And this is just one opinion from this report, but basically saying, look, the performance, the level of risk that's being taken on by the providers, we don't really see the results in terms of coordination of care, through the lens of the patient. Are the providers really at that level yet in terms of care coordination, or are they just doing, the bare minimums to hit certain quality metrics and get those incentives released? The second was, are the payers really being fair to the providers, and in terms of making sure that they're measuring and looking at the adjusting for age and for the health of the population in these arrangements? It looks like there's a red flag on that. And then lastly, maybe the most interesting is there seems to be all this consolidation going on, and it goes back to one of the first slides, and a desire to consolidate, and consolidation is supposed to mean control, and control means, well, if we have more physicians in a controlled environment, then we can get results. And that doesn't seem to be a connection yet. I think, and it's only human nature, but in this market and other markets, there's almost this emotional drive to say, well, we need to employ, we need to control, we need to have everyone under the same tent. But then really is the coordination of care there post-transaction? Are the physicians involved? And I mean that they should be invited. It should be the right structures and not death by committee, but we should have a sustainable structure in place to get results. And so that's sort of poking at this state and questioning, do we see a relationship between the two, between paying out these dollars and the consolidation in the market. I'm not going to go through all of these. I think this is where you could. Some of these are probably more applicable from the vantage point of the practice, and some more from the vantage point of the health system. But there is quite a punch list of things to go through when one's considering standing up an ACO or going to another level of risk. I mentioned the information systems. I think is overlooked too often. Practice operations. I have something that's just sort of popping right now. That we've got a lot of health systems wondering to what extent can I assist practices with planting, for instance, case managers in the practice or helping with IT. And Mark can touch on some of that now or later. But there obviously are limitations, and it's frustrating because it almost works against you. We're supposed to have the hospitals and physicians working together. We're not talking about large amounts of capital. We're talking about doing the right thing and helping to actually execute on some of these arrangements. The market dynamics, the competitive position of that practice or the hospital in that market, and the referral network is something, the consequences of going into some of these arrangements and looking at your own referral pattern of your practice, when you're going to be pressured to hold on to that patient and keep costs down, that can obviously have great implications on the impact on your relationship with other providers. Financial risk, we'll trip through a few of these, but really it gets fairly complicated for those that are not familiar with all the different layers of risk. But it's not it's not easy. You got to contemplate how much risk do I only get into shared savings and share on the upside. Am I ready and prepared? Do I have a track record to take risk on the downside? One thing I'll mention here, I had a group that was in the middle of a group in a hospital. We were talking, and they had in their mind that if they entered an ACO and took on some risk, those new incentive dollars they were going to fill the void of the reduction of their margin in their practice. Okay, the rude awakening is that for that particular situation, the average payout in that incentive was about $9,000 a year, and so this even goes back to the first slide that this is not if a group is not financially stable or the practice says, look, I want to focus on medicine, don't want to focus on business, and I want to look at some other arrangement, this might not be the ticket. Might be the right thing to do, but that's where the distinction between what are the financial issues of the practice and the level of financial integration that you seek, and whether or not you want to take on some risk through an arrangement with through an ACO.
Like you, I open the newspaper and I see, gee whiz, Vanguard and Tenet, that's interesting. Or South Shore and Partners, or Winchester and Leahy, or Dedham and Atrius, and you sit back and you say, what the hell's going on out there? And how do we get to whatever it is we're going? It's like we're running this big uncontrolled experiment, right? There's no control group. And so as you look at that and you say, what's the predominant factor? And in my mind, the predominant factor, I'll give it to you, in my view, in 3 words: no more money. There's no more money. And so when you say, there isn't any more money, then the question is, well, how do you go about planning for your future given there's no more money? And at the same time, given government is saying, and I think employers are saying, since there's no more money, somebody has to be accountable. And somebody has to be accountable for the cost of care, and somebody has to be accountable for the outcome of care. And so the issue that I think Dr. Dunlap was talking about, and what we talk about, is, well, who is that going to be? Now, the newspapers would tell you that that's going to be large hospital systems. because that's what seems to be coming together by and large, except when physicians come together. And being accountable, as you can see it from what Chris said, being accountable means I'm going to be responsible for how the dollars are spent. And at some level, I'm going to be responsible for the care that is given. Or if I'm not, somebody else is. And if you accept that premise, then you can say, well, okay, as I think about practice readiness to join an ACO, am I driven by fear that I'm not going to be the one who's going to be able to be accountable, or am I driven by the desire to be accountable? And as you think about the answers to those questions, you're going to have to assess your mindset. You know, what am I up for in this accountability thing? What are my options? If I'm not going to be accountable, who is, and who do I need to hook onto in order to assure me a future with a practice base so I can get referrals, or if I'm a specialist, you know, I'll get referrals or just get patients, knowing that the people who are accountable have stepped up to the plate and said, give me the money and I will be accountable. And the way I will be accountable is I'm going to control where the patients go. So those of you that are in Macaipa, South Shore, PHOs, whatever it is, know that you cannot go to a meeting without there being the word, quote, leakage, end quote, discussed fairly soon into that discussion about how we're going to manage care. So as you assess your practice accountability, practice readiness to go into an ACO, which is either an accountable care organization or another consultants organization or something that's got more letters associated with it, I mean, that's really the key question. Is, am I willing to be accountable on a risk basis for the money and the quality? That's fine. And if I need to do that, how do I analyze these things to figure out whether I have the capital, the friends, the connections, the skills, the desire? Or if not, then I better find somebody who is. And when you do that, it's part emotional, it's part financial, it's part retire, you know, how much longer do I want to practice? And so that's really the assessment I think everybody has to make. You're not alone. We in the legal profession are going through the same assessment. I mean, it's just, you know, you think about it, and before I came over here, I was in a meeting with a board, and they were saying, gee whiz, we ought to look at the airlines. And we all look at the railroads, and we all look at the banks. What happened there? So in the one sense, it doesn't make it any easier, but we're going through what happened in industry. So I think Chris has laid out, as you think about my readiness, that's complicated, but that's actually it. And I think what Dr. Dunlap did is he took this and he said, you know, if physicians are going to be accountable, then you got to step up to the plate and say, whatever that organization is, I want to be on the board, I want to be accountable, and I want to direct what accountability is. And that's an option. Or alternatively, somebody else will direct what accountability is, and it's the difference between being a vendor, so I will be a vendor to a big system, or I will be a partner or a part of an ownership of a big system. And I think, Chris, you know, that's kind of what the big level assessment actually is.
This is very true, and this is based on even outside of this study, empirical data that we've seen through our clients, that, you know, the myth that if you have a dominating market share, if you're employing a large number of physicians, and you have a strong financial position, then you're all set, and you're going to be the highest performing ACO in the market, and it's false. I mean, we have some really progressive 200-bed hospitals in the Midwest who've done amazing things and have incredible relationships with their physicians and get results. And the one that comes to mind doesn't have a stellar a payer mix, and has a little bit of room to grow in terms of market share. So I just wanted to flash this here because I think when we look nationally, I mean, I think some of these myths are out there, and it's just one more thing to consider when you're looking at who to partner with. this is a very busy slide, but I think you have it in your packet, and Jim, you can touch on a few of these. You could spend a long time on this, but basically what we're trying to convey is that if you move from left to right, the level of risk that you take on, that'll dictate the degree to which you need infrastructure and IT within that system. The extent to which you're going to have it's a risk reward. More risk you take on, eventually it'll pay a higher yield if you produce. And so there's many considerations laid out here, and I should say that it's not really three columns, particularly in the two to the right. Those can split out into many.
So I think the key point here is that as you think about these range of arrangements really relate to population health. As you're taking on accountability for the management of a population, you're necessarily going to evolve your skills, but one thing that's important to do at the same time is evolve your economic arrangements, ideally in a sort of a planned progression, so that as you develop the capabilities, you move from a shared savings arrangement towards a shared risk, and eventually towards higher levels of risk, commensurate with your ability to understand your data, understand what it requires to be successful, and possess the skills. And so when you're one thing to think about as you're considering where you plug into different types of arrangements, whether it's different ACOs or other organizational structures, as you're developing these capabilities, how do you participate in the opportunity to create an economically sustainable model for the extra costs and extra responsibilities that you may be taking on?
On clinical integration, we're not going to go through all of these, but there's two that we want to touch on that certainly overlap with the topic of ACOs, and that's governance structure and provider network. And so starting with the network, I think, again, there's a lot of systems that are looking at, well, I have a PHO, I have an employed group, I have loyal independent physicians, and so what do? Does everyone, so most participate in the PHO, but how do I ensure parity in terms of my relationship with an independent physician who's been loyal to the hospital versus somebody that's become an employed physician? And how does that look in terms of, we'll get into this in a second, but governance and leadership and participation in the network? And so what we're seeing is this isn't a standard labeling of these layers, but if you really start from the right and go left with me for a second, the network core, those that are fully financially integrated, there's ownership, there's governance, there's risk sharing by default by being part of it, potentially surplus sharing depending on how they're organized. Then you go left and you have those that are affiliates, and here there could be, I would even put in this camp those providers, physicians who have exclusive contract arrangements, so that this is becoming more popular where they're not employed, but they have a professional services agreement for 3 to 5 years where they've transferred their financial risk to the system. And so that goes far deeper than what we're talking about for ACOs. But you have network affiliates. And then further to the left, you have those that are now a little bit further on the outside, but that are active participants in the network, right or wrong in terms of how they relate to the others. And then to the far left are those who are truly independent and but obviously active participants in the network, but not taking on the level of risk that you see to the right. And so again, this isn't not trying to overly simplify this in the sense that every system has multiple layers or use these labels, but the point being is that, and I'll bring up Advocate again, the degree to which the PHO at Advocate and the employed group, they work together, highly coordinated, it works, and they don't feel any pressure to all of a sudden lure a lot of the physicians from the PHO and the community into the employed group at this point. I think the key word is choice. If a system is clear about the choices that it's offering to the physicians, that's where they'll gain credibility. We can offer MSO services to you. We can offer, we can do exclusive contract arrangements and shift risk. We can offer employment. We can offer, you can come in and participate in shared risk arrangements. And the next set of questions for the physicians would be, well, okay, now overlay those with my participation in committee structures and governance, and how is my input at a different level of value than somebody that's employed. I think the important point was brought up earlier in the presentation before this, is to really push and question where is the voice of the physicians, and how many layers, I'll use that, how many layers to the top of that organization. Because if there's some symbolic committees set up that are well attended in the beginning, but information flowing to those committees is not consistent, and it can start falling apart and becoming very weak, and you get the sense that you don't really have a sense of a direct input into how the incentives are distributed, or the direction of the network, or the next the next quality initiative that'll be rolled out. So it's important to ask a lot of questions if you're looking at an ACO. How exactly is it designed, or in the development stage, where is it going with respect to governance and oversight and physician participation?
I would just say, everyone has a lot to do, and those of you that serve on medical staff committees and so forth know they can take a lot of time, so you have to kind of ask yourself, why bother? Why should I get involved in governance? Somebody else will do it. It's a lot of work. Got to do a lot of homework. And I think if you think about this accountable care business and what it means somebody's going to allocate the dollars that come into the system. So the dollars are going to come in, and somebody has to decide what it's worth for a service by a primary care physician as opposed to a specialist, as opposed to the hospital, as opposed to the DME supplier, as opposed to anybody else that dollar is supposed to cover. And so if you're not at the table, it's harder to have a voice in that allocation. So there's one reason. Second is, the reality is, no matter what the RAC audits or anyone else, might think, the people who actually are responsible and can make good clinical quality decisions and decide what the protocols all be are the physicians. And so I think if the physicians don't get involved, that means somebody else will use interqual or some other standard and say, well, why don't we just do it, we got a cookbook, let's use that. And the only way that will be avoided is if the physicians get in there and say, this is what we think good clinical quality actually is. The other thing that happens is, people decide who's going to be a member and who isn't going to be a member. And that can have impact on, the inputs and the outputs. And if the physicians are important constituents to decide, who ought to be a member of this club and who shouldn't. And lastly, and I think Chris was talking about this, the organization has to engage in strategic planning, which can, adds the question, what products are we going to participate in? Are we going to be in the exchanges? Are we going to be Medicare Advantage? Are we going to do Medicaid? What are we going to do? And again, the people that actually see the patients and are interested in the patient population have to get in and say, we're willing to do, this kind of product, but something, that kind of product, there's not enough money in it that's going to allow us to practice the way we think we should. Let's pass. And again, those are four key answers to the question, well, why should I get involved individually or collectively as physicians? Those are the reasons. Who's going to see the patients? How are we going to get paid? We collectively, what are the products going to look like? And sort of what's our plan? So I think that's why it's important to get into this and have a voice.
Well, I'll just add real quick. I would ask for the charge of the various committees because too often that someone comes up with an interesting name, they have good intentions, And like I alluded to earlier, the committee gets off to a decent start, but you really have to ask, what's the process? Where do the recommendations go? How are they elevated? Are they taken seriously? And so it's not just spending the time to join the committee, but really asking the question in terms of the integrity of the committee and the process for vetting recommendations that those committees produce.